Welcome back to the deep dive. Today we're tackling something really critical. We're decoding the language of fetal heart monitoring, FHM.
Yep, a strip of paper.
Exactly. We're using professional lecture notes, the kind of dense stuff guiding real-time decisions. Our goal, cut through the noise, understand the data, and know what action it calls for.
Right. Think of that FHM strip as this constant feedback loop. It's all about assessing fetal oxygen and how the central nervous system is functioning, basically.
So it's more than just looking at squiggles.
Oh, absolutely. We need to really get the diagnostic funnel from baseline assessment right through to, critical interventions.
Okay, let's unpack it. Before we even touch the machines, why are we doing this? For you listening, what actually puts a patient on the monitor? What are the main reasons?
The source material is pretty clear. There are routine situations and then more high-risk ones.
Like active labor.
Yeah. The simplest one is active labor, or sometimes just checking if labor is starting. But mostly, it's about risk factors.
The things that flag a pregnancy as high risk anyway.
Exactly. So any kind of worrying bleeding, or if there are preterm uterine contractions,
Okay.
and medical conditions too, like gestational diabetes, mellitus, GDM. These things they change the uterine environment.
And physical issues with the pregnancy itself?
Definitely. Things like placenta previa, where the placenta covers the cervix, or placental abruption, where it detaches, those need constant watching.
Makes sense.
And of course, multiple gestation twins, triplets, you name it, they get monitored because the risk of, say, growth issues is just higher.
Got it. And then there are reasons specific to the baby's condition.
Right. We monitor if there's any hint of fetal distress.
How would you know?
Could be from an abnormal non-stress test, an NST, or if there's meconium in the fluid, or maybe a bad biophysical profile, the BPP.
Okay.
And finally, if the pregnancy goes post dates, past 40 weeks, placental function can start to decline, so monitoring becomes really important.
That definitely sets a high-stakes scene. So if those are the risks, how do we get the data? That brings us to the tools, right? External versus internal monitoring.
Yeah.
Big trade-offs there.
Yeah, it's always balancing how invasive you want to be against how specific the data needs to be.
Let's start with external. The Toco and the heart rate monitor strapped on the outside.
Right. External monitoring is non-invasive. That's the huge plus.
So less infection risk.
Much less infection risk. And you don't need the membranes to be ruptured or the cervix dilated. Any nurse can usually place it pretty quickly.
Sounds great. Why wouldn't we just always use that? Where does it fall short?
The main limitation is the contraction data, that external Toco. It tells you when contractions happen and for how long.
Frequency and duration.
Exactly. But, and this is key, it cannot measure the actual intensity, the strength of the contraction.
Okay. That seems like a big piece of missing information for labor progress.
It really is. Plus, if the person moves around a lot or there's more abdominal tissue, the signal quality can drop. Needs lots of repositioning sometimes.
So if you need really precise data on both heart rate and contraction strength.
Then you consider internal monitoring, but there are definite hurdles to clear first.
Yeah, you can't just jump to that. What are the requirements?
Strict safety rules, the membranes must be ruptured, no way around that.
Okay.
And the cervix has to be dilated, usually at least 2 to 3 centimeters, so you can actually get the monitor in.
And the baby's position matters.
Yep. The presenting part, usually the head needs to be down far enough, engaged, and critically, you don't do it if there's vaginal bleeding.
Yeah.
Risk of injury, infection, hemorrhage, just not worth it.
But if you meet those criteria, the data quality is much better.
It's the gold standard, really. You can spot abnormal FHR patterns earlier, and you get that accurate measurement of contraction intensity that external monitoring misses entirely.
And variability, you mentioned that's key.
Yes, you get a much cleaner, more accurate read on FHR variability. And funny enough, sometimes the person can actually move more freely because the internal monitors aren't shifting around on the belly.
Okay, now for the main event. Reading the actual strip. The sources lay out 6 key steps. Let's walk through them. What defines fetal well-being on that paper? Starting with baseline.
Right. This is your funnel. Step 1. Find the baseline. That's the average FHR over 10 minutes, ignoring the big ups and downs, the accels and decels.
Just a steady rate.
Exactly. Then immediately, step 2. Assess variability.
Why is that so crucial? What are we actually seeing?
Variability is maybe the single most important sign of how the baby's central nervous system and heart are doing. It's the little beat-to-beat jiggle in the heart rate.
Those minor fluctuations.
Yes, and we classify it minimal, moderate, or marked. Moderate variability is what you want to see. That's the gold standard.
What does moderate tell you?
Tells you the baby's well oxygenated, the nervous system is active, it's responding properly, minimal or worse, absent variability. That's a big warning sign. Suggests hypoxia, maybe injury.
Got it. Moderate variability, good response. Okay, step 3 is the good stuff on the strip. Accelerations, accels.
Yeah, the heart rate jumps up temporarily. We look for the 15 by 15 rule.
Meaning?
The heart rate has to go up by at least 15 beats per minute, and that increase has to last for at least 15 seconds. See those? That's strong evidence the baby's doing well.
Okay, but if you don't see those, or if the rate drops, that's when we worry. Steps 4 and 5, finding and identifying decelerations, the dips.
Precisely. If you see a decel, the next job is figuring out what kind it is, early, late, or variable.
And knowing the type tells you the cause.
Exactly. And that classification drives step 6, intervention. What do you do about it?
Okay, before we get to interventions, let's look at the other half of the strip, the Toco trace, the contractions. What are we measuring there?
For contractions, we look at strength, frequency, duration, and Montevideos.
Montevideos. That sounds specific.
It is. It's only with internal monitoring. You calculate the total pressure generated by contractions over 10 minutes. Gives you that hard number for intensity.
But for spotting problems, we're looking at abnormal patterns, right?
Mm.
Like hypotonic versus hypertonic.
Yeah, those are key. Hypotonic means the contractions are just too weak or too far apart to make the cervix change. They're ineffective.
So the intervention is?
Evaluate, probably augment. Maybe start or increase pitocin to make them stronger.
And hypertonic. That sounds like the opposite problem.
It is. Hypertonic activity means the resting tone, the tension in the uterus between contractions is too high. It's not relaxing enough.
Why is that rest period so important?
That's when the baby gets most of its oxygen. Blood flows best to the placenta when the uterus is relaxed. If it's always tense, hypertonic, blood flow is restricted. Not good.
And that lack of rest is even worse with the other big red flag pattern,
Yeah.
tachysystole.
Yes, and tachysystole has a strict definition. More than 5 contractions in a 10-minute window.
Wow, that's frequent.
It is. If you see that many or if they're piling up without good relaxation in between, that's tachysystole. Big problem.
What's the response?
First, check the baby. How's the FHR pattern? Then, almost always, you reduce or stop oxytocin if it's running.
Because the oxytocin might be causing the excessive contractions.
Correct. And you might even give a tocolytic drug.
A tocolytic, what does that do here?
Tocolytics relax the uterus. They quiet it down. If the uterus is overstimulated, hypertonic, or tachysystolic, giving a tocolytic can force that needed rest period for the baby to recover oxygen.
Okay, this feels like the perfect lead-in to the big decoder ring for all this.
Yeah.
The VEAL CHA mnemonic, you said this connects the pattern to the cause.
It's absolutely essential. VL CHOP instantly links the fetal heart rate pattern, the VL part, to the likely cause, the CHA part. Transforms the squiggles into meaning.
Okay, break it down for us. VEAL.
Right. V stands for variable deceleration.
And the C in CHOP.
C means cord compression. The umbilical cord is getting squeezed, usually just briefly.
Got it. V is variable, C is cord compression. Next.
A is for early deceleration.
Okay, and the H.
H means head down or head compression. This often happens just from the pressure of a contraction pushing on the baby's head.
And you said this one is often benign.
Yeah. Early decels often mirror the contraction and aren't usually too concerning on their own. It's kind of expected during pushing.
Okay.
Next is A.
A stands for accelerations, the good ones we talked about.
And O.
O means, okay, things are good. Fetus is well oxygenated.
Simple enough. A is okay, which leaves L.
L is for late deceleration.
And this is the most worrying one. P means
placental insufficiency.
so the placenta isn't doing its job properly during the contraction?
Exactly. There's a problem with oxygen exchange. The heart rate drop happens after the contraction peaks because the oxygen dip hits the baby with a delay. That pattern suggests a more serious, sustained issue with oxygen supply compared to a quick cord squeeze.
Okay, that makes sense why lates are so concerning. So
Yeah.
once you see a pattern that isn't reassuring like lates or maybe recurring variables, you act fast with the 7-step intervention protocol. This is the immediate bedside action, right?
This is the rapid response playbook. Step 1, boom, reposition mom, turn her onto her left or right side.
Why does it help? Often takes pressure off the vena cava, improving blood return to her heart, or might shift the baby off the cord. Quickest potential fix.
Okay, reposition first. Then what?
Step 2. If the pattern looks like hypoxia, or if mom's O2 sats are low, give oxygen, usually 10 liters via a non-rebreather face mask.
Step 3.
Fluids. Give an LR bolus lactated ringer solution intravenously. Increasing mom's fluid volume can sometimes boost blood flow to the placenta.
Makes sense.
Yeah.
What about step 7, stopping oxytocin? You mentioned that earlier.
Yeah, step 7 is DC oxytocin. If the drug might be causing or worsening the problem, you stop it, often done very early, maybe right after repositioning.
Okay. Now, step 5 seems really specific, talking about amnio infusion and C-sections.
Right. Step 5 lists more targeted, sometimes more drastic actions. It specifically says amnio infusion only for variables.
Only for variables. Why just variables?
Because variables mean cord compression, remember, VC. So if you infuse sterile fluid saline into the uterus through a catheter.
You add more fluid around the cord.
Exactly, you cushion the cord, often resolves the variable decelerations. But if things are really bad, severe lydatias or variables that don't get better with these steps,
Then it's C-section time.
then cesarean section CS becomes the necessary intervention to get the baby out quickly.
And the last step, communication.
Step 6. Notify the provider, the doctor or midwife. You've started the initial fixes, but the primary provider needs to know immediately what's happening and direct the next steps or prepare for delivery.
Wow. We have covered a ton of ground, from why we monitor, to the tools, to reading every squiggle, and finally, to VEAL, CHOP, and the exact steps to take.
Yeah, understanding those 6 strip elements in VLGP really gives you the language. It decodes that vital data stream.
It really demystifies it. Knowing that a Lant decile points to placental insufficiency tells you why the response has to be so quick.
Absolutely. It connects the dots between the pattern, the physiology, and the urgency. That's the whole point.
Exactly. So as we wrap up this deep dive, let's leave you with something to think about, circling back to that specific intervention.
Amnio infusion.
Right. We established that variable decels mean cord compression, and late decels mean placental insufficiency. The protocol says amnio infusion is only for variables, not for lates.
So the question is,
Thinking about the underlying cause, cord compression versus placental insufficiency, why would adding fluid, the amnio infusion, be a logical fix for the cord issue, but completely ineffective or maybe just irrelevant for fixing the placental oxygen supply problem? Something to mull over about matching the intervention to the cause.